Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Sarang Mahanaik, gastroenterologist at Apple Hospital, Indore, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hi, myself Dr. Sarang Mahanaik. I am a consultant gastroenterologist working here in Apple Hospital, Indore.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
So, IBS means irritable bowel syndrome. It is a disease in which your gut becomes hypersensitive. So, mostly patient presents with symptoms such as diarrhea, altered bowel habits. He has to pass stool multiple times and has a feeling of incomplete evacuation. IBS has various types in which mostly it is like IBS-D, that is IBS diarrhea, IBS-C, in which there is constipation instead of diarrhea, and other is IBS-M, in which there are both symptoms, like patient sometimes has diarrhea and sometimes has constipation. So yeah, that's what is IBS in simple terms.
In your experience, how does a typical IBS patient present in an OPD?
So a typical IBS patient presents with symptoms of altered bowel habits. It can be in any phase, like it can have diarrhea or constipation. Diarrhea means patient has to pass stools multiple times in a day. Volume or the content of the diarrhea is not important, but the patient has to go to stool multiple times. Or constipation means that patient is feeling constipated. He is not able to evacuate stools daily. And there is always a sensation of pain in abdomen, which often gets relieved after passing stools. So this is usually a common presentation of IBS patients in my OPD.
What are the biggest myths or misconceptions you hear from patients about IBS?
So the patients of IBS are usually symptomatic for a long duration of time. It means that they may be symptomatic for 2 to 3 years. So they have various misconceptions. One of the most common misconceptions that it is a very dangerous disease and they have a threat to life. So it is not a dangerous disease. It's just a lifestyle of stress-related disease. It can be treated easily with some lifestyle interventions and medications. Other misconceptions are that the patient is having cancer or a very dangerous disease. What we can say is dangerous to life or threat to life, which is not the case in this.
How does modern lifestyle, food habits, stress, and sleep contribute to IBS?
When we look about the pathophysiology of IBS, IBS is considered to be a multifactorial disease. That is, many things are contributing towards your symptom, like your lifestyle, what you are eating, how is your stress level, how is your sleep, whether your sleep is adequate or not. Everything has an important contribution in your disease-related symptoms of IBS.
What are the top 3 red flags that make you suspect IBS in a patient?
So, patient having symptoms of altered bowel habits, pain in abdomen, constipation, feeling of incomplete evacuation, of long duration, like more than 6 months, at least more than 6 months, and every other diagnostic test coming to be normal, like lab investigations, colonoscopy, endoscopy, everything is normal. So this is a common scenario in which a patient is suspected to be an IBS patient.
What are some common mistakes in diagnosing IBS at the primary care level?
So what I see is primary care level, many patients who presents with symptoms which are suspected to be an IBS, these patients are usually overdiagnosed and overtreated with antibiotics and other therapies, which are usually not necessary. IBS can be easily diagnosed with proper history taking and all red flag signs. When all red flag signs has been eliminated, then patient of IBS can be diagnosed without overusing all diagnostic tests and over prescribing them with other treatments.
Are there any warning signs where a physician should immediately refer to a gastroenterologist?
Yes, definitely. If a patient is having severe loss of appetite, involuntary loss of weight, blood in stools, then these are the warning signs when the physician should immediately refer to a gastroenterologist and the patient should be evaluated further.
Once IBS is diagnosed, what is your first line approach to management?
So once we diagnose IBS, if we have ruled out all other chronic organic disorders or any other chronic illness, then the first line of management is simple. That is lifestyle changes. Patient should be advised to get hydrated adequately. He should be advised for physical exercise to be done, and some dietary interventions like low FODMAP diet or lactose-free diet should be advised. And if at all these things are not working, then some pharmacological treatment can also be tried.
What's your opinion on the role of rifaximin in IBSD? Where does it fit best?
So rifaximin is a gut-selective antibiotics. It's usually being prescribed in IBSD, but it has also a role in IBS-C. So rifaximin is what rifaximin usually does is it destroys all the bad bacteria which are present in gut. We call it in our language CBOD. It is small intestinal bacterial overload. It is useful in these conditions. And irritable bowel syndrome has definitely rifaximin has been shown to be beneficial.
How important is patient counseling in IBS management? What key messages do you give?
So patient counseling is of utmost importance in the patient management in patients with IBS because patients are often very anxious. They want to know the nature of their disease. So we should counsel them that the disease is not life-threatening, it's a treatable disease, and it is very easily manageable with simple lifestyle interventions and the basic pharmacological therapies.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
So diet definitely plays an important role in management of IBS, especially in IBS-D cases where high FODMAP diet has been shown to cause the symptoms of IBS-D. So I definitely recommend them to follow a low FODMAP diet, get hydrated adequately, increase fiber intake in their diet if there is IBS-C, that is IBS constipation. If there is bloating, then we advise them to take fiber in moderate amount, and he should also avoid all the junk food with preservatives, sugary drinks. This food also triggers the symptoms of IBS, therefore it should be avoided.
How do you simplify IBS counseling in a busy OPD setup?
So it's very easy to counsel a patient of IBS. First of all, patient should be counseled that IBS is not a disease for which he should be worried. That is, it's not a disease which is threatening to his life or which can cause some morbidity. When the patient is being told the nature of the IBS, then he is relieved, and we should tell him what lifestyle intervention, lifestyle changes should be done in your daily day-to-day life, what dietary changes should be done, and we should also advise what drugs or what therapy should be taken so that the patient is symptom-free. Thank you so much.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.